How we doing? Besides tired. At least that's what I'm gauging. Okay. You guys got a psych coming up on Friday? Yeah, be careful. He's still in the back. I'll save all the comments. It's okay. It's okay. All right. Any questions from yesterday? I went through a lot of those different arthritises and arthropathies. And you don't have to head nod, raise your hand, right? If you went through the slides to review last night and kind of are trying to pick out those differences, right? If you're having a hard time finding those, please let me know. Okay, kind of take my time to go over those to help you distinguish between these different conditions, considering one of the first like ologies, and it's abstract with just a picture, and we don't have all the pathophys behind it. So utilize that information to help distinguish between the two with the picture as well. So as you get in there, you're like, okay, good, diabetes, Charcot, right, that kind of thing. This perimenopause, what was this one, that kind of, if you're having a hard time with it, let me know. I'll try to help you break it down a little bit more. But we only have one more arthritis left, and that's the infectious kind, okay? So really what this is it's right what it says, infectious. So it's a hematogenous seeding of the synovial membrane from an infected source elsewhere. So typically we will see this. This could have been a blood infection. It could have been an open fracture that wasn't treated with antibiotics, right? That could lead to a septic or lead to infectious arthritis, or an osteomyelitis, which could lead to this, right? So anything that has an infection that involves the joint can eventually lead to an infectious arthritis. Your pyogenic and your non-pyogenic, look at your most common guys right there. Staph aureus pyogenic, Mycobacterium tuberculosis non-pyogenic, which means which one, if you're gonna get an infectious arthritis, which type do you think is more common? Right, the pyogenic one, right? Right, the tuberculosis one is not very common at all, so it's gonna be the pyogenic. Ironically, the pyogenic one is the one that is worse. It's the one that happens quicker. It's the one that we kind of catch. So the more common one is the worst one. So that's not good. Usually it's monoarticular, so one joint, right? So monoarticular. There haven't been very many things so far with arthritises that we talked about being monoarticular typically. This, secondary osteoarthritis, right? A lot of the other ones dealt with bilateral joints, so bilateral hands. Primary osteoarthritis is usually the bilateral joint, so that's a distinguishing factor here, okay? And your location. So adults, typically the knee, children, typically the hip for your pyogenic. We do see it often in the hands due to human bites. Now, unless you're anybody from Florida? I know it's been a few years, so the bath salt thing has kind of like been washed away, right? But unless that happens again, how often do you think we're worried about human bites? Daily, so daily maybe a little extreme, but more often than you might think, right? Hopefully you guys aren't gnawing on each other's hands and things around here, but it's not usually a human bite that we're concerned about. People don't run around biting each other's hands, but what is typically the injury that would mimic like a human bite? Punching, bar fights, fights in the dorms, things like that. I go to punch someone in the face, I catch their tooth, it breaks the skin on my hand. Human bite, right? It's tooth introducing bacteria into the hand. That's what gets overlooked a lot of times. Like, well, no, you didn't get bit. No, but if you got into a fight, you punched somebody, you broke the skin, that's the same introduction of bacteria as somebody biting your hand, right? So keep that in mind. Human bites need antibiotics or human tooth breaking. So when you see those people that come in, I fell. Okay, what did you really do? I fell. No, you didn't fall. You didn't fall and get a cut just right here, right? So get them to tell you the truth. Usually, and we'll talk about this later with a boxer's fracture. Usually, you got to like get them more fuzzy and be like, listen, I'm not your command. I am not your first sergeant. I don't care what happened. I just need to know what really happened so I can treat you appropriately so you don't get worse, right? And then usually they're kind of like, I punched a guy. Or I punched a wall. Was it a wall or was it a person, right? If it's a wall, that's different than if it was a tooth. So you got to pry it out of these young soldiers and airmen, and you know it's just craziness. Feet and diabetes, right? Again, when we get those diabetic ulcers, right? That's an open wound, so that can introduce this. And the crappy part about that, like we talked about with the Charcot's, is that we can't feel it, right? But this is going to look different than the Charcot's did on imaging. So like you just said, diabetes is Charcot. Yes, it could be this too, but you saw what the Charcot pictures looked like yesterday. You'll see what these ones look like. All right. So we talked about that already. Pyogenic is very rapid destruction of the joint compared to other forms of arthritis. All the other arthritis take time, right? And they're not something that happens like overnight. These things happen pretty quickly, and we'll see what that looks like. The non-pyogenic is usually longer, fits with the other arthritises. X-ray is your initial study. Every other arthritis has been X-ray as a study of choice. Infectious arthritis is MRI. Same thing as that osteomyelitis, because we're looking for the infection. MRI is your study of choice for infectious arthritis. X-ray has been the study of choice for all the other ones. So don't get excited when you see arthritis and you just want to hit X-ray. Figure out which one I'm asking for first. All right. And then that just talks about the pyogenic, non-pyogenic, very rapid versus long course again. Here is what your pyogenic looks like. So again, remember Charcot's. Charcot's was typically the knee or the ankle, right? And it just had that giant swollen area that just the bone kind of just was degrading. It was arthritic. It was nasty looking. But now we look here. This is more focused on some of the smaller joints, right? And it's not the whole thing. I can still make out the rest of the bone, but you can start to see that the joint is starting to degrade and get eaten away. Right? There's like no bone here. It's gone. It's eaten away. Okay? So basically the joint got infected and the bacteria started growing, started causing pain, redness, swelling issues, and started eating away at the bone. Here's your risk factors, right? Same risk factors that you have whenever we're kind of dealing with any kind of introduction to a bacteria from outside a source. IV drug use, big one. Steroids, why? Not only does it weaken the immune system, but typically the way they get steroids is through the IV, or it was because it does drop our immune system, so it makes it a little more susceptible. And then all of our joint surgeries and joint traumas. Why? Because I'm opening the body to the outside air. Now they should be done sterilely, but things happen. It's rare, but things can happen. Biggest one is the joint prosthesis. Total knee replacements, total hip replacements. That's why they're getting repeat x-rays all the time, and you'll see this. Ortho will likely be the one ordering them, but you'll start to see after the joint replacement, they'll get x-rays every couple of weeks for a couple of months. And just to make sure all the hardware stays in place, but it stays in place pretty good. It's really watching for any type of infectious arthritis or any other complications that might come on from that. Super, super rare, but they want to catch it early if it does happen, so that way they can fix it. And then immunocompromised patients, which leads into diabetes, folks. Here's another one. Right? I know it says staph and gonococcus most common. The last time we said it was just staph. Staph, if I'm going to test you on it for most common, it's going to be Staph aureus from the pyogenic. Okay, it's going to be the staph. Gonococcal is on there because you're going to see a lot of gonococcal when you get out in the clinic if you're staying in the military. So be aware of it. Right? It's not just an STI. It can cause issues in other areas. So I want it on your radar. Rapid loss of joint space, monoarticular. Biggest thing, right? There's not very many things that we have seen in this course so far that have done something that have basically eaten away at the bone in the joint area. It's pretty much this and osteomyelitis. They both look very similar. They both have very similar symptoms, which means they're both not going to be answer choices for a question like this. Because there is no way for you to look at this and tell me whether or not this is osteomyelitis or this is an infectious arthritis. Not possible. So if this is on there, I'm trying to get you, it'll be one or the other. Here's your non-pyogenic. Much slower loss of growth, loss of joint space. Right? This is not something that's going to happen very quickly. Not something that's going to happen very quickly. It's right in here. You can see how this is a little more radiolucent on this side of the knee than on the other side. More radiolucent here than on the other side, right? This is going to be your indirect tuberculosis spread, so this is going to be super rare. especially in our population. We don't have a lot of tuberculosis patients. When would I be concerned about this? Well, if I have somebody who has a history of tuberculosis, now I'm going to be concerned because they've already been infected with it, or if they came back from a tuberculosis-ridden area, but it doesn't happen very often, but it is a type of infectious arthritis. So it would be wrong of me to cover just one and not the other without giving that information. Okay. Questions on the infectious arthritis? Yes, sir.
For the kids, because it's most common,
Yes.
are we going to be trying to diagnose pictures if they have as well?
Unlikely. I don't even think I have a child hip picture put in there. Yeah, good question. So the question was, I said most common for hips in kids, are we going to diagnose it in a hip? If that were to be the case on anything, right, I mean, I'd say unlikely. This would be one of the questions in that aspect to where the hip picture would be adjunct and you wouldn't necessarily need it to answer the question. Does that make sense? So it would be helpful if you did, but if you did just a vignette, there would be enough information there for you to get the answer. Other questions? All right. Do we remember our 4 types of erosive arthritis? Okay. Rheumatoid, gout, psoriatic, ankylosing spondylitis. Good. At least look at it a little bit. That's good. Types of infectious, 2 kinds. Pyogenic, non-pyogenic, right? Staph aureus for pyogenic, indirect tuberculosis or just mycobacterial tuberculosis for non-pyogenic. Any questions on arthritis? All right. Everybody take a look at the giant line that's red at the bottom of this slide. Okay. Why do I cover it? Because you're going to see it. And you need to know, or at least have slides for you at your disposal in phase 2 and in your clinic for which ones are the bad guys and which ones are the good guys. Which ones need further testing and which ones can you go, you're going to be fine, it's not a big deal, okay? But these are not necessarily easy to always pick out on just an image, so we're going to cover them just so you have examples of them, all right? FYI, which means we'll breeze through it here fairly quickly because I'm not testing you on it, and I want to expose you to it. This is going to be your chart that you can have, right? That you can break down the different things. We're going to cover a lot of these, all right? We've already seen some of them, like the multiple myeloma ones. We've seen the metastases down here in the 40-plus age group. But we're going to cover these. This is just one nice little slide of it all together. And another one, which shows you kind of what they look like. Again, don't put a lot of brain power. This is going to be reference because these kinds of things in bone lesions could be on, and I don't write it, but could be on your ortho test in phase 2, for example, right? They could be on any type of HEMONC type questions in senior semester when you get to oncology. And I don't want that to be the first time you've seen this stuff. You'll have enough stuff to try to learn for the first time. Let's try to expose you to it a little bit here. This is another one chart, tell you the most common areas for different things. So that way when you're in clinic and you get that bone lesion, and you're sitting there and you're looking at it and you're like, oh weird, I got it around the knee. Okay, maybe it's Ewing sarcoma or osteosarcoma because those are the most common areas. So I have this chart available for you to take a look and see what's going on. Here's what some of these things look like. So left side is normal, right side has the osteoid osteoma. Lots of bone words there, right? What it is it's just a little radiolucent circle in the cortex of the bone, most commonly in the tib-fib area. Okay? Most commonly in the tib-fib area. That's not air in the bone, that's a bone lesion, radiolucent bone lesion. There's no need to evaluate it further. These are the ones that are scary for the patient. This is one of the more important ones I want you to kind of commit from memory, just so you know. This is called an osteochondroma. It's basically just that overgrowth of the bone here. Is this a pediatric or an adult x-ray? Pediatric. Look at the growth plate, right? Look at the growth plate. What do we do for this? Anybody know? That's the question. Is it asymptomatic? It's kind of like that malunion. If it's asymptomatic, we're going to leave it alone for now until it becomes, it will probably eventually become symptomatic, but especially when it's a kid, I don't want to do surgery unless I have to. So unless it's causing pain or causing issues, we're going to leave it alone. Most of the time it's causing symptoms, because that's why mom or dad brought them in, because they're having pain. But if they were coming in because they had shin splints or something down here, and you just happen to get the x-ray and see this, and there's no pain in that area, right? Then you don't necessarily need to do anything. Every once in a while, mom and dad will feel soft tissue, what is that lump? And then that's why they'll come in, right? But as long as it's not causing any pain, usually we can leave it alone. It'll eventually get removed. But if they're gonna have a surgery and cut it off, what if it comes back? Now you have another surgery. So we only wanna mess with it if it's causing issues. Fibrous dysplasia. Okay, so this is the fibrous sheath that's kind of around the bone area. You see the difference between normal and abnormal? Do I need you to know that's fibrous dysplasia? No. But I do need you to know that this is normal, so when you see that, you go, I'm not just letting that go. We're going to evaluate that. Okay. And a lot of times, bless you, by the way, a lot of times the radiologist isn't even going to call this fibrous dysplasia. They're just going to turn around and say, hey, there's this abnormality. This will probably be recommended MRI for further evaluation to figure out what the heck's going on. But you'll just follow that radiological report and just say, oh, order an MRI, great, come back in and get your MRI. This is the scary stuff. Osteosarcomas. That's malignant. That's not good, right? And you can, now, what's the difference between this guy? The biggest difference between this guy and this guy? Diffuse. What's the other thing we talked about? Let's go back to our mammal stuff. We talked about our lesions. Characteristics of probably benign versus malignant. Margins, right? Clear, well-defined, little growth on the outside. Not overly concerned about it. I have no idea where this starts and ends. Like this, anything that doesn't have the clear margins in medicine for the most part is concerning for malignancy. Little hairs in the back of your neck should stand up, right? This needs to be addressed. You don't need malignancy. It's true, I mean you don't, but so this just kind of goes over. It says bone lesion, but it's the same for those breast lesions and any lesions we see, right? There's really, it says 3 ways really I care about: well-defined or ill-defined, right? Sclerotic is in your notes. Technically, we talked about sclerosis and sclerotic lesions more in that avascular necrosis area. You can use that to describe a lesion. I care more about the borders of the well-defined and the ill-defined. Location, we didn't cover it in this section, but we covered it in the fractures. Same concept, right? Distal, mid-shaft, proximal, where's the lesion at? So if you're describing a lesion to an ortho person or an oncology person, hey, they have a well-defined circular radiolucent lesion in the proximal area of their tibial cortex. Great, you just told me everything I need to know about an osteoid osteoma. Okay, so just prepping you guys for the future in that. That section is not testable. Do not commit any major brain power to it, but have it readily available for other courses and leave it to phase 2. Skull. Who remembers all the bones of the skull? Basilar, spondylolisthesis, intercalated segment. There's your main vocabulary. Here you go. If you don't remember, it's all right here. Okay. Now here's the fun part about the skull, the facial bones. What if I asked somebody to pick out the location of the sphenoid or the ethmoid bone on the x-ray? That kind of area, right? This is to show you that if I'm concerned about certain areas of the body, yes, there are x-rays, but this is really hard to see, right? X-rays are not great for facial bones and skull because everything is just superimposed on one another. I got everything all in here. I can't trace cortex. Like, I don't know where any of these things kind of started. Now, some of it, orbits, I can see the outline of the orbits quite well. So X-ray can be used quite good for orbits. The lateral of the facial bones is good for a nasal fracture, which I don't have on here right now. We can see some significant fractures or divots if it's in the outside of the skull on this. But outside of that, when it comes to like the facial bones, it's not really good. So what do you think we're going to want to use if we're concerned about any abnormalities in that area of the body? CT, good. Here's your lateral. So this is kind of what I was talking about. The nasal bone is like right here. It comes down right here. It's right behind the line. So you can see the nasal bone quite well. You can see the sinuses really nicely. So sinus x-rays are really good because you can see them superimposed with one another. And what's nice about it is once you get to seeing normal on the sinus x-rays, people are like, hey, that should all be air. But a lot of times if you have like blockage or like mucus or fluid filled up in here, it'll be that whitish gray and then air up here, so you'll be able to see those air fluid levels. So sinus x-rays are really nice. But here's your anatomy slides. Take a look at those. Now look at the detail on the CT. Right? Now I can really see the orbits on each side. Orbits. I can make out the zygomatic arches really nicely. I come over here with what slice is this on the left? What kind of slice? Oh, think about it. It's the head. Axial. Axial slice. Here's my coronal slice. Here's my sagittal slice. Okay. So, but overall, looking at my axial, right, I can see my mastoid air cells, my zygomatic arches. I can even see a little bit of the nasal. I can, and then when you scroll in and out, ooh, that's not good. When you scroll in and out, you can trace those sinuses really nice. You get the ethmoid sinuses, the sphenoid. If I got up here, I would eventually see my frontal sinuses really well. So you can scroll in and out of the CT on the facial bone to get a good look at everything. Look at my skull line here on my lateral. I get a nice, beautiful side view, sagittal view of the skull. Really helps me look for any kind of fracture. So if I'm concerned, you're probably going to get an x-ray first. Why? Because it's easy, it's quick, it's not a big deal. But your CT is where you're going to go for these facial bone concerns or these brain or skull issues. Right? So here's the different kinds of fractures you can have. Okay? Cross off the word initial in blue. That's confusing. CT without contrast or non-con is the study of choice. Please cross off initial. That is confusing. I know it's in blue, so it means study of choice, but it seems really weird to do initial study of choice. The reason for that is it is the initial study of choice, but when we're talking about like strokes and stuff like that later on, MRI is the next step. That's kind of why it's worded. I don't like it. So take off initial. For what you guys need to know, CT non-con is the study of choice. You can have different kinds of fractures. The linear fracture is basically just in the bone area. Your depressed fracture actually depresses the skull down. Your diastatic is going to be a fracture that goes across one of the sutures. And then your basilar is down here at the base of the skull. Basilar, base. That's the most concerning. Because if that's fractured, then we're also definitely concerned about a C1, C2 kind of fracture, right? But CT without contrast is your study of choice for any acute head trauma. Any acute head trauma is a CT without contrast. Here's just some x-rays for you to look at, normal versus depressed fractures. So you can absolutely see them on x-ray. Here's the problem with x-ray. I know it's fractured. Great. Do I know the extent of the damage? Don't. Because what am I concerned about primarily with this type of injury? Brain bleed, brain damage, right? Brain bleed. I can't see the brain. I have bone blocking all of my brain, right? So I know it's fractured, but I'm gonna have to get a CT to look at the brain anyways, which is why your CT non-con is just your study of choice for your head trauma. Because this gives me one piece which is not enough for me to diagnose or treat this patient. It's almost worthless, but you will do it sometimes because you have time and they gotta wait to get the CT scanner, and what if you see something else? It is. Again, CT non-con head, then you gotta wait for bleeding. Why non-con and why not contrast? I'm evaluating for bleeding. We've been talking about contrast with the blood and the vessels and all of that this entire time, right? We talked about the aorta. Soft tissue and fluid look the same, so in order to see what's blood and what's the walls of the aorta, I gotta give that contrast. But in the head, we don't want to give contrast. Does anybody know? It's not necessarily irritating. It has to do with actually the density of the brain compared to the other parts of the body. Acute bleeds actually show up white on a head CT, and we'll see some pictures of this. So if an acute bleed shows up white and highlights, like right here, compared to the rest of the brain matter, right here, this is all blood right here. So if an acute bleed is going to show up like that, if I give contrast and I highlight all the vessels in the brain, how do I tell the difference between the normal vessels and the bleed? I can't. Right? They're going to look the same. This is why we don't do contrast in head CTs most of the time. Acutely, we never do it because we're looking for bleeds. The only time a contrast in a head CT would be indicated would be if you did a head CT for some other reason, not for a bleed, you noticed a mass in the brain, a tumor of some sort. Now we're going to redo it with contrast to see if that tumor lights up, to see if it's got the blood flow and if it's, benign, malignant, that kind of thing. But for acute head trauma, non-contrast CT of the head, because I want to see that bleed. Okay? So what you end up having is acutely it shows up white. Halfway through, after it happens, it's you can't really tell. But then later on, when it's chronic, in other words, I've had it for a while, it shows up dark. Because that blood has had time to no longer kind of be liquid form, it's starting to congeal a little bit, it's got a different density to it, so now it shows up dark. Now, in picture alpha, what side of the brain is that bleed on? The patient's right. Remember, CT and X-ray are the opposite. So if I were to give you this picture and ask you, and later on you'll be able to tell me if it's epidural, subdural, we look at it, right? And give you choices of right or left and different types of bleeds, once we see how they're shaped and you learn that, this is enough in alpha for you to determine whether or not it's right or left and what type of bleed it is. I do not need to give you markers because we've learned opposite, right, for X-rays and CTs. Don't let right or left trip you up. Let's talk. Go ahead.
What was the black arrow for in the big problem?
They're just showing the same thing on both sides. This is one of the ventricles. I'm sorry, I should clear that. The white dotted arrow here is one of the ventricles, and what's happening is, I was going to get into it later, we'll do it right now. What's happening is the blood is pushing on the brain matter, right? The head is an enclosed area. There's not a whole lot of space there. So when we get blood, it's pushing it over. So we're getting what's called a midline shift, and it's pushing the ventricle over more than where it should be. These aren't the greatest photos for that. We're going to talk about it in each bleed, and you'll see it more. But the same thing is kind of happening here. It's what it's showing. This is your midline, and you look at your one ventricle here, but here's your other ventricle that's getting shifted and pushed over due to the bleed. Okay? Yes, sir.
What's the timeline for even associated with the bleeds?
I don't have, there's nothing like in the book like specific timelines. Acute is going to be like it just happened. Well, we're talking these people hit their heads, they come into the ER within 24 hours typically. So I would say 24 to 48 hours for acute bleeds. There's not a good timeline for chronic, per se. It's not like, oh, once you hit a week, it's chronic, or once you hit 2 weeks, it's chronic. There's nothing definition-wise based off of that. The way you guys should be able to distinguish between the two, and I think the reason is that you can tell from the CT whether this is dark or bright, if it's acute or chronic. So the imaging will tell you if it's acute or chronic, as opposed to the actual timeline. But most of your acute bleeds from trauma are gonna come in within 48 hours of the injury. Because they're gonna have other symptoms too besides the trauma due to this. Right. Let's talk about different types of hemorrhages and the patients that can have them. So we have our intracerebral hemorrhage, okay, which is just intracerebral. But look at all your risk factors: hypertension, current smoking, excessive alcohol consumption, hypocholesterolemia, drugs, old age, male, Asian, chronic kidney disease. 80% of our population has risk factors for this, right? The ones that really stand out are going to be your alcoholics and your smokers with your hypertension. Those top three are top three for a reason in the list, right? You got somebody who's hypertension, a smoker, chronic alcohol, they're going to be at a much higher risk for intracerebral hemorrhage. Most of your causes are trauma, right? The point of impact shears the vessels. The vessels are weaker because of those top three things, right? The hypertension, the smoking, the alcohol, it weakens our blood vessels, makes them more prone when you have the trauma to get these intracerebral hemorrhages, okay? CT findings may change over time. So if you have a patient that comes in and you do a head CT and you're concerned about a bleed and it's normal, but there still is, eliciting signs of confusion, signs of delirium, signs of a brain injury, do not just turn around and go, you're fine, go home, have a good day. You can do a repeat CT, or you can admit them and order an MRI if you need to. That's what we kind of talked about that a little bit, because the lesions will show up better on an MRI. MRI will show those TIAs, those mini strokes, some of these really, really tiny hemorrhages a lot better, but it's not emergent, right? When we're doing the CT, we're looking for a bleed that is emergent. Needs a surgery, needs a release, something along those lines. These little ones are going to take time. There's no such thing as an emergency MRI. You're very rarely going to get an MRI tech to come in on call to do something like this. They're probably already in the clinic, because MRI places in hospitals start at 7 a.m. and go to 2 a.m. some places, different shifts. But they probably already have a full schedule of patients. I had my ankle MRI. My appointment at BAMC was 10:45 p.m. I was like, oh, lucky me. It's like an hour exam. I didn't get home from anyways. So it just goes to show, right, they have a schedule already. So you're not going to be getting an emergent MRI on anything for the most part. Here we go. So here is what they look like, intracerebral, right? Could be anywhere within the meat, as I call it, of the brain area, right? It's not just out towards the edge. The other bleeds we're going to talk about are going to be kind of hugging in some way up against the skull, right? These are more into kind of the meat of the brain, or filling up the ventricles. This is blood in the ventricles here. These are your intracerebral hemorrhages. They're within the main cerebrum and brain matter of the head CT. Not hugging around the outside, not in this nice little center area, right? There's a white dotted arrow there to show you that there's nothing in that center area, because we're going to talk about another bleed that sits in that center area. This is your intracerebral. So how would I distinguish that from this course? Well, learn for yourselves when we get to them, your epidural, your subdural, and your subarachnoid. Really know those. If the bleed doesn't fit one of those three categories, call it an intracerebral hemorrhage. Because there are very specific things that go with each of those three bleeds that we're going to talk about that make it known to those bleeds. And then if it's not one of those three, call it an intracerebral hemorrhage. I'm not going to get hung up if I give you one with blood in the ventricles. I'm not going to get, we talked about it as the category of ICH, intracerebral, right? So I'm not going to give you this and have intracerebral and intraventricular and be like, you should have chosen the more specific one. No, it doesn't have its own slide with symptoms and things like that. So this would be considered intracerebral, and ventricular won't be a choice. All right. So we'll come back to see if you have questions on this one once we go over the other three, because they are more kind of specific in those three. Subdural, risk factors. Elderly, alcoholics, anticoagulation. Anticoagulation is going to be a risk factor in a lot of these, right? Because if they can't clot, they're easier to bleed. All of these are mostly dealing with cranial trauma. Doesn't usually just happen, usually there's trauma, okay? What happens is the bridging veins between the dura and the surface of the brain tear. Much, much more common, 6 times actually, than the epidural, which we'll talk about next. Symptoms. This is going to be a key piece. When I give you head CT images, if I want you to diagnose on this test, there are 2 ways to do it. One is you know what the stuff looks like, you know where it's supposed to be, and you can do it by the image. If you completely ignore all that, because you're like, I don't really care about this, I just like to study words, there are going to be patient symptoms that are going to lead you towards these types of bleeds because they act differently. So there are 2 ways for you to know this material for this course, okay? So the symptoms here: acute progression of symptoms, rapid progression, headache, irritability, just out of nowhere, right? For the acute ones. All of a sudden, he's got this massive headache, and I'm agitated, I'm irritated, right? And I have a rapid progression of symptoms. The key thing is going to be here is the crescent-shaped hematoma just below the dura that follows the surface of the brain. Okay? Follows the surface of the brain, crescent-shaped. Look at it. Acute headache and irritability, suddenly, and follow the white area of the bleed. Now you're looking at it going, what do you mean? You'll see when we get to the epidural. So think of it as a crescent. It looks like a little moon, and if I trace the shape of the skull or the brain along the edge, the other side is shaped the same way. If I trace the shape of the skull, the other side of the bleed is shaped the same way. Okay? There are multiple ways to tell that there's a bleed here. One is the white area for the acute bleed that we talked about. But then we also briefly talked about that midline shift. Look at where both my ventricles are. And then also the other ventricles down here. I have both of them on one side of the brain. I should have one on one side and one on the other. And here's my midline. If I come up, everything's being pushed over this way. Everything's being pushed this way. It's because of the bleed here. Why is that important? You're like, look at that. Look at that big white crescent. I can see the bleed. I don't need to look at the ventricles. What about this picture? Or this one here? Is the bleed super obvious? No. Why? It's more chronic. It's darker up here, more chronic. But what tells you something's abnormal? The shift, the midline shift. That's the scroll through. I don't see anything. Ooh, that's not supposed to be there. Right? Let me look a little bit more and make sure I'm not missing something. It's that midline shift. But the biggest thing with the subdural, crescent shape, looks like a moon, goes along with the shape of the skull and the brain. Is this a right or a left bleed? Is this a right or a left bleed? This is a left bleed. Opposite. Your right is the patient's left. CT and X-ray are the same. Your right is the patient's left. Your left is the patient's right. Okay, epidural. Epidural hemorrhage. Typically the middle meniscal artery. By the way, the pathophys on here, guys, I'm not going to ask you artery questions. Okay? I'm not going to ask you artery questions. You need to know it at some point, but not for this. Neuro, for sure, right? But I'm not going to ask you artery questions. I care that you can pick these things out. Headache, vomiting, loss of consciousness. Here's the key piece to epidural. A period of lucency interspersed between two periods of loss of consciousness. This could happen in clinic, or this could be reported by a loved one when they bring them into the hospital or into the ER to see you. Right? They said they were having a headache, they lost consciousness, then they woke back up, they were talking to me about something, and they lost consciousness again. Right? A period of lucency in between two separate episodes of consciousness loss. Vomiting can happen with a couple of them, but this is a big one with this one. It was not on the subdural one. We did not have vomiting. We had headache and irritability. This one has the headache and the vomiting and that period of lucency between two different loss of consciousness. Also, the subdural didn't have loss of consciousness on there. The epidural does. Okay? Imaging, CT head non-con, this is the same for all these bleeds. Right? Focal bleeding from the medial artery. This one now is a convex appearance. It says lens, that's a technical term. I like little football. Right? Look at the difference now. I trace the skull area and it's bulging out. The bleed is bulging out. It is not going along the lines of the brain of the skull. It is bulging out. Looks like a little football. That's your epidural. Did everybody see that? Okay, so it comes outward, loss of consciousness, sometimes period of lucency in between two episodes of consciousness loss, and I have the little football along the edge of the brain. So now we haven't even gotten into it yet, but you can see how these two bleed significantly different from that intracerebral one, right? These are shaped this way. These are almost always along the edge of the skull. One goes along with it. One bulges out against it. Here it is on a nice, pretty slide comparing the two. Because of the head bleeds, these are the two that get confused the most when we're dealing with academia or even just in clinic, right? Because they're very similar. They're bleeds in the same area. They have some different symptoms. Okay? And they're shaped differently. Questions on these two? Lucid interval. Okay. Subarachnoid hemorrhage. Thunderclap headache. Okay. This is that worst headache of life. When you're asking that question, when you get to Clinicore next semester, is this the worst headache of your life? This is what you're evaluating for. This one does not need trauma. Sure, trauma is a reason, but look, trauma is the third bullet. So yes, it can happen in trauma. These things usually happen suddenly due to a cerebral aneurysm. Okay? CT non-con, just like all the other ones. Here's the catch with this one. If you have a high suspicion for a subarachnoid hemorrhage and you get the CT and it's negative, and based off of what you'll learn more in neuro by the time you get on this program and you're out there in clinic, and you still think it's a subarachnoid hemorrhage, you're not trusting the CT. You're going to do a lumbar puncture. Because if it's a subarachnoid hemorrhage, there will be blood in the cerebral spinal fluid, and that is how you'll find it. This one also has altered level of consciousness and vomiting, but this is the only one that has the thunderclap headache. The way I word this to my patients, I'm like, is this the worst headache of your life? They're going to have someone like, oh, well, you know, kind of, they're usually bad, but not this bad. If they're doing that, it's probably not. So then I will word it a little bit different. I'm like, so when I say worst headache of life, what I'm saying is like, did it come on suddenly and it was unbearable? Like, if I walked up behind you with a ball-peen hammer and hit you in the head, did it feel like that? Oh, no, it didn't feel like, great, I'm not worried about subarachnoid hemorrhage, right? Paint a picture for the patient so they understand what worst headache of life is. It's kind of like when you get the person who walks in and their ankle hurts and they're like, hey, doc, like, how bad's your pain? Oh, it's like a 9 out of 10. No, it's not, right? It's not a 9 out of 10. A 9 out of 10 is I sit there and I break your ankle with you sitting right here. That's a 9 out of 10. You can't walk in like that. Sometimes you have to alter how you talk to the patient to get them to give you an appropriate answer, especially on something like this. But why do we call it a subarachnoid hemorrhage? It's in the subarachnoid space, but does it look like a little spider? Right? Looks like a little spider. He's got less legs. He's had trauma. It's fine. But it's like a little spider in the center of the brain, right? So that's the way I remember it, right? Yeah, it's in the subarachnoid area, but really, it kind of looks like a little spider sitting out there, right in that center area. Legs coming out here, coming out there, little spider. So, yeah, CT non-con, but do not just use that as imaging, and that's where this is for later, if the lumbar puncture is inconclusive, and usually they'll be like positive or negative. If it's inconclusive, like they can't give you a good answer, then you'll jump to the CT angiogram, but don't worry about that. It's just there for you in your clinic stuff. I'm not going to get that deep on it. I need you to know that's a CT non-con, and I need you to know based off of the patient presentation and or the image, can you pull out of the subarachnoid compared to the other bleeds? Sir?
Will we get other views other than axial or
Unlikely. Yeah, good question. Will we get other views other than axial? For head CTs, not usually. Most of them are axial views. Because honestly, when it comes to brain bleeds, that's usually all you really need. Those coronals and sagittals are mostly used when you're trying to look at like the facial bones or looking for like the fractures or the orbits or things like that. So most of your regular head CTs looking for bleeds is going to be just your axial CT. Okay, before we go into facial fractures. Now that we've seen the other three hemorrhages, right? The epidural, the subdural, the subarachnoid. You see what I was talking about with the intracerebral. Like if you get these three down and the bleed is not in those areas, lump the rest into intracerebral, right? Because that could kind of be anywhere. It doesn't have those kind of clear definitions that these other three have, right? Which one is the most emergent one, the most concerning one? That's on the screen. Yeah, subarachnoid. Good. Okay. And then which one comes with the lucid area between two levels of consciousness? Epidural. Use that slide to look at the football shape versus the crescent shape. So you see what I'm saying? Like there's two different ways, right? If these pop up, you can know just images and possibly get through it if you know it well. Or patient presentation can get you there too. Preferably, we want you to use the patient presentation and your knowledge of the image together to make you feel really confident. Then you got it all. All right. Facial fractures. CT. We already kind of talked about it in the very beginning, right? Really, in today's day and age, there's really no reason to get an x-ray. You saw that at the very beginning, how you can't make out any of those facial bones really. Maybe the outline of the orbits, maybe the nasal bone, which how often do we care if the nasal bone's actually fractured via x-ray? Not very often, right? So CT is what you're going to do. Most commonly, looking for orbital fractures. What do you think the most common way to get an orbital fracture is? Bite. Same way as the human bite, right? Usually a bar fight, a dorm fight. I keep saying bar fights. I probably have more fights in the dorms now than you do in the bars, especially if you're on a training base. So you're concerned about orbital fractures, primarily a blowout fracture, right? Did you learn about that in AMP at all? Like how you get like the muscle kind of caught and the eye won't move where it needs to go? No? Or HUT, we talked about it in ophthalmology and all? Oh, it's next block? Okay, I wasn't sure how far you got in it yet. You'll see, he'll talk about orbital fractures and how it can catch, and then like, I won't move. Right there. Entrapment of the inferior rectus muscle leading to upward gaze and diplopia. We'll talk about that more next semester. I'm not going to get you into that, or not next semester, next block with ENT. I need you to know that if you're concerned for a facial fracture, you're ordering a CT, non-con, non-contrast, right? Because we're looking at the bones. I don't need contrast to look at bones. And there's a couple of things we will look and see here. So here is your CT. Again, to show why we don't do x-ray. I have no idea what's going on here. I can't make out any details on any of these guys. But when I do my CT, I know I should have a nice round, gap there in my orbit, right? So what we end up having here is we have a fracture of the orbital floor. This one's not as severe, but we have the fracture of the orbital floor, okay? And then we're starting to get some fluid coming down into our sinuses. Now, I don't know what that fluid is. Probably blood, but again, we don't know because all fluid looks the same on CT and X-ray, so I can't say for sure it's blood. It's probably blood. I can't say for sure. The more concern is the orbital floor fractures. Everybody see the fracture. Which eye or which orbital wall socket has the one with two arrows? The right. I think I've hammered that home enough. Okay. You can also look at the sinuses up in here and compare the two sinuses. You see the excess of fluid in the right sinus compared to the left sinus, right? So the nice part about these CTs, especially when you do these additional slices, and what slice is this again? Good, coronal, is I can compare the two side by side. So I definitely have some kind of excess fluid, probably blood, but don't know for sure, compared to the left side, because it should look the same on each side with the air cell, or the air of the sinuses, and it doesn't. This is why we do CT. Questions on the orbital fracture or the facial bones area and the scanning that we do on that? No. All right. Just some blue slides. We just covered this stuff. There's the fractures again. There's the CT for you to look at. There's some acute and chronic bleeds. You guys can look at these on your own. Note the answers are in the notes. And there's your epidural hematoma. Questions on that show? Slideshow. All right, take 10, come back at 3. Drive forward. Okay. Ow. So with what we've talked about so far, what type of imaging do you think this person's getting when they come in?
X-ray.
Let's just think about it. What?
Chest pelvis X-ray.
Okay, chest pelvis X-ray. Not a pan CT. We don't pan CT, people. We don't pan CT. But I will send them to CT for what? Head and probably neck, right? Or C-spine. If they're what?
Stable.
Stable. Do not send unstable patients to CT. Again, you will send them, and they'll be unstable, and you will send them, and about 45 seconds later, code blue in radiology, code blue in radiology. Like, oh no, that's my patient. So do not send stable patients to CT. So yeah, so definitely a CT of the head, a CT of the C-spine. I like the chest and pelvis X-ray. We haven't really talked about it too much yet, but yes. And then from there, we're probably going to order regular X-rays on any injured extremities or any other injured parts of the body. Right? We're not going to send for a full CT only because that would be a lot of radiation, and they don't necessarily need that. When I'm just going to be looking mostly for fractures. Yeah. This is where you get your pelvis X-ray from, right? Why we're going to do this. What are they examining for here? You guys know? Instability, right? The pelvis is one of the quickest ways, I'll say quickest ways, is one of the easiest areas to hide massive internal bleeding. The pelvis rim alone can hold 4 to 6 liters of blood. It can hold a lot. So what they're looking for is stability of the pelvis to see if there's any kind of fractures, right? They used to call it, I think I briefly have it in here, like the whole open book, closed book kind of thing. You know, what are we going to do for it? We'll talk about pelvic fractures here a little bit and when you need to be concerned and when you don't. But that's what they're trying to check for. Is there some kind of stability here? What type of bleeds do you think are happening in the pelvis? Oh, sure, abdominal, I guess. What type of vessels, arterial or venous? It's venous. And somebody said it. Venous, believe it or not. Very rarely are they arterial bleeds, because here's the thing. The arterial bleeds can happen, those more femoral, right? But what ends up happening is with the fractures of the pelvis, they're venous bleeds, and that's why they're sneaky, because they can hold 4 to 6 liters of blood. The patient will appear stable. They will look stable because they're having this slow bleed into their pelvis, and you don't even realize it until all of a sudden they become not stable very quickly, right? And that's why we'll talk about the fast exam, why we do that, is we're trying to catch that bleed prior to it becoming that issue. And that's where the pelvis injuries get really scary, is because they're usually venous bleeds, so they don't happen quickly. And wait, we're going to go with spine and pelvis in this block. Look at that. That segue. Not like the segue this guy was on, no. Okay, so we'll start off with the spine. 80% of Americans have back pain. Low back pain is the #1 diagnosis in this country, if you look at medical charts. more than diabetes, more than hypertension, low back pain. Most of it is due to our own doing, right? It's excessive weight, it's lack of fitness, most of it, not all of it. And I say that to be very careful of looking at somebody who's obese and overweight and just assuming that their back pain is because they're obese or overweight. There could actually be something else going on there. So don't just assume, know it's on your differential, so don't just be like, oh, well, when you lose weight, go away, right? You could be missing something. But back pain is very, very common. Yeah. Okay. Yeah. You CPR certified, just in case. Okay. We gotta keep it professional here, so somebody else will jump in. No. These are all the things we're going to talk about. Some of the causes of back pain, most of them. We're not going to talk about all of them. But look at your differential, right? My goodness. What's causing it? I don't know. It's investigated. You try different things, they come back for follow-up, you try other things, right? It's very difficult to first appointment to be like, your back pain is because of this, right? You can rule things out, and that's where x-ray is going to come in. So we're going to talk about all the different areas of the spine. We'll talk about even the coccyx a little bit and how worthless that little bone is. And then we'll talk about the pelvic ring. The coccyx causes more problems with patients. It hurts. There we go. Spine anatomy. Not going to belabor it. It's there for you. You had it last semester. Right? We're going to talk about what it looks like on x-ray and different things. But know your anatomy of what you're looking at. Intervertebral disc anatomy. Okay? Know your difference. Know where they're supposed to be. Know what it looks like. I'm not giving you anatomy questions, but anatomy is important to understand what you're looking at from an x-ray standpoint. So now we're finally getting into it, folks. We're finally getting into the body parts, right? We got the spine, we got the pelvis, we got the lower and upper extremities we have left in this block. So now we're going to start focusing on those actual abnormalities of each of the body parts as opposed to disease processes. Because we're going to go through our techniques. Do you remember what level of the spine has the greatest space between the discs? It is lumbar. Right? It's where you know that cushioning. It's where all that weight's at. Good. We're going to start with the cervical spine. Does it just make sense to go from the top to the bottom? Here's your anatomy specifically for the cervical spine. So to say, hey, it's a lot of slides, but like some of these are just anatomy for your review. So you've got to go back into your freshman thing, pull up the anatomy. It's right here. Here are your muscles that attach to the cervical spine. We don't do a lot of muscular evaluation in this course. However, a lot of your neck and shoulder pain is likely going to be contributed to some of these guys. And if you know where these guys are, you are going to help the patient out a whole lot more and a whole lot quicker because you're going to know what type of exercise programs to print out, what type of stretching to print out for them, because you're like, oh, it's going to be your sternocleidomastoid muscle, most commonly used when there's a kink in the neck. So one of the muscles is most commonly done. You know where it's at, you can treat it a lot easier by just stretching techniques and printing them off stuff. Yes, this guy right here. All right. What do you notice about this x-ray? Those looks normal, right? Based off of what you know about the C-spine, the cervical spine, and the labeling that I have on it, what do you notice about it?
C1 through 3 is hard to see.
I'm missing C1 through 3. It's really difficult to see on this frontal view. Why? Because I have a giant mandible in the way. This is one of the reasons a lot of times when we're evaluating the cervical spine, if we are concerned about it, we'll send them for a CT. I can't see it. Now, other pictures I can do, which we're going to look at to help me see it, but I want to be sure there's no fracture in that sometimes, so I'll send it for a CT on the cervical spine. But I want you to pay attention to some of the anatomy. So the pedicles are out here on the outside, right? These little guys in the center, these are your spinous processes, right? They're posterior, they pop up really nicely. What's this big, dark, tube-looking thing? That's my trachea. Air is black on x-ray. That's my trachea. Yes? The reason I can see my spinous processes really nice is because those are thick bone that sit right behind that airway. So there's all air there, so I can get in there, it pops really nice, really pretty, I can see those spinous processes. Right? That's my trachea. Now, how do I know that's C4, C5, C6? What's the first vertebrae that has ribs? T1, rib, rib. Count up, if that's T1, C7, C6, C5, C4. Here's my top rib coming in, top rib coming in, T1, C7, C6, C5, C4. Do you need to know how to count like that? Yes, yes you do. Yes, you do. Because if you see an abnormality, you got to be able to tell somebody, hey, it's on C5, or it's on C7, or it's on C4, or whatever the case may be. There are different ways, depending on the image, to do our counting. For the AP or the frontal view, find T1 based off of the ribs, and count up from there. Okay. Here's your lateral view. Now all of a sudden, what can I see that I couldn't see on the frontal? C1, 2, and 3. And look at that. Main right here. C1, C2, C3, 4, 5, 6, 7. 1, 2, 3, all the way down. Now, how do I know that's T1? Can I see the ribs? Kind of hard to see the ribs. But with the lateral, I know exactly where C1 is. So I can just count down, and once I get to 7, I say the next one is T1. This is probably one of the best lateral cervical spine x-rays you will ever see. The majority of them, because patients are larger and don't drop their shoulders enough, end up with shoulder space kind of hiding T1 and part of C7 sometimes. So that's why we count from the top and work our way down, because we're not always going to see T1 and the C7. Ideally, we would like to, but especially when you got like either larger patients, and I don't mean just larger as in obese, even the really muscular people, right? They have like just huge traps and all that stuff. They're like built like this. It can hide that T1, C7 introduction just because they can't get their shoulders depressed down far enough because they have all that muscle up in that area that's going to kind of give issues with the x-ray. So when we're doing a lateral, we count from the top down. We do the frontal, we find T1, and we count up. Know how to count your vertebrae. But here we can see we have our spinous processes here in the back, okay? Those come down nicely. We'll talk about the lines here in a little bit. Lamina is right here on the anterior portion of, anterior portion to the spinous process. Your superior articular process and inferior articular processes right here, causing those joint spaces all the way down, okay? Your disc space, you notice how I can't really see it in the vertebral disc. Why is that? It's soft tissue and fluid. Can't really see it, right? But we know it's in between and we know the spacing is there. All right. There are oblique views sometimes that you can get. The reason for the oblique views is I get a beautiful picture of the intervertebral foramen right there. Do you need to know whether or not and when to order these things? No, not for this course. But these are x-rays you can see that I need you to kind of pay attention to and see that. Now the nice part about the oblique view, right? I'm still counting from top to bottom because look, doesn't this rib look like it's going into C7? It's tricky. It's because it's oblique. It's on a 45-degree angle, so it throws off the projection. So you're still going to count from that spinous process right here, C1 down to C7. Do not count from the ribs up on the oblique. That is only a frontal view thing to do for the cervical spine. Because this will trick you. Now let's talk about how we evaluate a spine. So you've gone through your normal process, right? You went through your cortex, you went through your medullary canal or cancellous bone, you went through your disc spacing, you went through all of that. And you're like, okay, that's everything we learned, I'm done. Well, with the spine, there's additional steps. We have these lines that are sitting right here. And everything should be in line with one another. And so there's 4 sets of lines you want to look at. 3 mostly are the most important. We look at the spinal laminar line as well. But what you're just doing is you're tracing these lines along the spine to see that everything lines up nicely. It doesn't need to be straight like the drawing, right? Drawings are easy to do straight, but you need to know your process of your spine, right? We know that the cervical spine has a lordotic shape to it. So that's okay as long as they're in line with it. I'm going to try to draw on this if it's funky, but I'll give you an example of why we want to watch for that. So if all of a sudden I have my line, that's not, oh, of course now it shows up, all right. Ignore that one. If I draw my line and it all lines up smooth, right, that's good. Well, what I'm watching for is if I'm drawing my line and all of a sudden I see something like that, right? All of a sudden some of the vertebrae or one of the vertebrae shifts over and it's not a smooth line going from top to bottom. It's almost like a joint space, right? So it's almost like a joint space to where the bottom of the vertebrae and the top of the next one should be fairly in line with one another. That's how it should look. This is the concern that we're looking for, and that goes for all of the lines, right? So you have your anterior vertebral one, then you got your posterior vertebral, so you're doing the posterior vertebral body, okay? Then you're doing your spinal laminar line, which is just in front of your spinal processes, really along the lamina, and then your spinous process. Most of the time, you're going to find your abnormality in your vertebral bodies, most of the time. The reason we do them all is because sometimes you have a fractured spinous process and that can go through, throw things off as well. But you just want to make sure they're kind of smooth and going all together. Does that make sense? All right? Looking for any step-offs is what that's called. So here's another one, kind of showing you how the lines go and then matching it up with the CT, right? So if you did a CT, you could do the same thing on the CT. I know it's a blurry CT, but it's really just meant to show you the vertebral bodies and the spinous processes and how you can still draw those lines even on a CT when you get that good slice. You're just looking to make sure it just is where they're supposed to be. Everything's aligned correctly. Here's how you do it on the frontal view, or the AP. All I'm doing is just checking the sides, and then following those spinous processes down. Those should all be straight. Right? We want everything in a line. Those should be nice and straight. These are all normal x-rays. We have not seen any abnormals yet. Giving you lots of normal pictures to utilize in your slideshow. Here is the frontal view, or the odontoid view, that can allow me to see that C1, C2 area. Okay? Got my dens right there. Got the lateral masses. Got the axial joint. It's all right in here. And so how did they do this? They literally have the patient open their mouth and they shoot the x-ray straight through the back of the throat. Because the mandible is what was hiding that in the first place. So I get the mandible out of the way, get the teeth out of the way, and shoot straight through. Why is it antiquated? Because, man, we're having to repeat these things so often, right? A lot of times you do it and, like, you clip the top of the odontoid because they didn't open their mouth wide enough or they weren't tilted back. Or you get that, but you don't get the joint space, the lateral masses here. And so, like, on average, for an average x-ray tech, this was a 2 or 3 shot process to get a good one. We're going to be doing that, and it's that important to look for a fracture here, right? Because this is the stabilization point of that cervical spine. I don't want any questions. We're just going to do a CT. So some places, though, if you don't have a CT scanner, you need to get this, and you need to be able to look at it so that way you can try to see if you see a fracture or not. So that's why we still talk about it, because yes, it's mostly antiquated, but what if you don't have a CT scanner? You still got to be able to see this area. I'm not testing you on the types of odontoid fractures, but you will see that next semester. okay? But it's counterintuitive. All right? Counterintuitive. The lower the type, the more concerning it is. The bigger chunk that's fractured, the easier it is to stabilize and heal. The smaller the chunk that's fractured, the more concerning it is and unstable that it will be. Okay, that's all you need to know. Hey, look at that. Does everybody see the odontoid fracture on the CT? Wow. That would be a type 2. Very good. That was my next question, but that's fine. Just jump ahead. It's okay. Type 2. I already said it was a CT. What kind of slice is it? Coronal. At the back. And because we get CTs on the neck or the cervical spine most often, it would be silly of me to not give you what normal kind of looks like. Okay? Here's your sagittal slices, here's your coronal slices, sagittal slices, coronal slices. Okay, there's your normal CT. See how easy it is to just draw the lines? Just draw the lines on both these guys. Don't have the spinous process line on this one, right? But that's okay, because I can scroll in and out if I have a real CT. But the biggest thing is here, this side one, the sagittal, and get these nice little anterior vertebral, posterior vertebral, and really the spinous process line, or the spinal laminar line. So, what's all this right here in the center? Spinal cord and CSF. There's both in there. Can't tell the difference on CT. Why? Because CSF and spinal cord are both soft tissue and fluid. They look the same. But if I were to get an MRI, I would be able to see the spinal cord versus the cerebral spinal fluid because there's enough contrast there to be able to see the two. So there's a little hint for a spine. You're like, is this CT or MRI? Can I make out spinal cord versus CSF? If I can't, it's going to be a CT because that all looks the same. Look at that lead in. Look at that MRI. Now you know where the spinal cord is versus the CSF. What's also fun about MRIs, what can I see on the MRI that I can't see on the CT? The discs. Look at my little discs. Little discs. But on the CT, I see the spaces, but I don't see the discs. So besides the graininess, besides the way we're looking at things for spines, this is another good way to tell whether or not it's an MRI versus a CT. Another one comparing a CT to an MRI. Ignore the notes in this one. I took out the slides that talked about contrast resolution versus spatial resolution because it was confusing and not necessary to be able to interpret films. So if you are still on the PowerPoint and you see the notes section, you can ignore those questions. This is just meant to show you a CT versus an MRI side by side. Another normal MRI, don't get hung up on the yellow arrow, blue arrow, red arrows, just helping you understand it. I am not going to be asking you, where is the vertebral artery? Oh, that's right there. No, that's not the kind of anatomy I'm looking at getting on you guys. If I ask you an anatomical question, there will be something along the lines of like, what is this? And not like a CT or something, and you're distinguishing between, is it a trachea, is it an aorta, it's something big, right? It's not going to be, where's the vertebral artery? That's not important for this class. So we already talked about the importance of the vertical lines for the cervical spine. That goes for most of the spine images. We want to make sure everything's in alignment and make sure there's not any shift or damage, right? And looking for any abnormalities, ligament injuries, occult fractures. We need to immobilize the neck, right? If we see one of those lines is off, we have to put them in a C-collar until we can get them healed up and better. So now we're going to start comparing some normal to some abnormals. So again, normal here, big blue arrow sign. Now, maybe that didn't jump out right away, and that's okay, but if you took your time and did your lines, you'd be like, what the heck? What is going on here? Drawing my lines, and I got this bulge out instead of this step off. These are osteophytes. This is basically cervical spine arthritis, causing those osteophytes. But this can cause significant pain, primarily in what position do you think she's having more pain than not? Flexion. Right? Flex down, those osteophytes hit against one another, can cause pain when looking down. These are your anterior bone spurs. Okay, let's start talking about spine abnormalities. In general, this is not just cervical in nature, this is just spine abnormalities in general. Spinal stenosis is one of the things that we can be concerned about, that we can find. Okay? Let me jump down to the bottom. X-ray is often the initial study, but MRI is your study of choice on the spinal stenosis. Now we're starting to get into stuff where we're like, okay, is it CT or is it MRI? MRI is your study of choice for spinal stenosis. All right, it's most commonly in the cervical and lumbar regions. Okay, can happen for a multitude of reasons. Typically, osteoarthritis, the osteophytes, the spinal canal narrows for whatever reason, causing stenosis on the spinal canal. Spondylolisthesis. You have to say that 5 times fast as part of the exam. Spondylolisthesis we'll talk about. We'll see different pictures on that. Okay. But looking for spinal stenosis, MRI is your study of choice. Here are all the reasons I just said why it can happen. Facet osteophytes, posterior vertebral body spurs, we talk about spondylolisthesis, bulging discs. What we're looking for is, for some reason, the spinal canal is narrowing. It's being stenosed, right? The spinal canal is not just going to narrow on its own. Something is going to be infringing on that spinal canal, causing the narrowing, causing the stenosis. So what is that abnormality? Is it an osteophyte that's pushing back into the spinal canal? Is it a bulging disc that's pushing back into the spinal canal, right? Something, is it a tumor, right? Something that's taking the spinal canal and compressing it and making it smaller than what it should be. That's what we're looking for with spinal stenosis. And all of these things are possibilities. You cannot tell spinal stenosis in this picture, but what this is an image of somebody with severe osteophytes and degenerative disc disease, which is the medical term for arthritis in the spine, degenerative disc disease, right? Look at how, what I like to call is noisy on this, right? Remember we looked at those obliques? Go back to those obliques real quick. There we go. See how nice and open these facets are? Or the foramen? Look how nice and open they are, right? That's how they're supposed to be. That's where our nerves kind of go through. We like to see them nice and open. Look at this poor person. I can barely see it here. I can see it down here. This is nice. This one down here isn't bad. This one down here isn't bad. But look at how noisy or congested this one is, with all the extra bone, all the extra osteophytes from that degenerative disc disease, that inflammation, and growing that extra bone. And you start to see the extra osteophytes here on the anterior portion of the spine as well. I have almost no intervertebral foramina up here. Right? And where's my disc spaces? Right? It's almost non-existent here. This one almost kind of looks like it's starting to calcify because it looks the same color as the bone. Right? And I finally start to see some disc space maybe a little bit here. Right? So this is one of the issues that can lead to spinal stenosis, right? The arthritis of the spine. See, like, are you finding a fracture in that? Probably not. Right? It's hard to find. There's a lot of stuff going on there, but this would be concerned for osteoarthritis or degenerative disc disease. Okay. Spondylolisthesis. That's the slippage when we talk about that step off of the vertebrae. Okay? Now, everything we've learned so far when it comes to moving parts has been named for the distal segment, right? Where's the bone moving? Where's the joint moving? Distal segment. It wouldn't be medicine if we didn't make it confusing. When naming the slippage of the vertebrae, it's named for the superior segment and the direction it's going compared to the rest. I didn't make it up, promise. So this one in particular, and this is why counting is important. I'm going to do it first and we're going to go through it. So 1, 2, 3, 4, 5, 6, 7, T1. So C6, C7. So I would call this in the center one here. I'm going to count it again. 1, 2, 3, 4, 5, 6, 7, T1. Draw my line. You see right here is where it stops. It doesn't line up. It goes in a little bit and comes back down. Right here. Right here. This would be a C6, C7 anterior spondylolisthesis. You see that? You name it for the two vertebrae that are affected, the one above and the one below, C6, C7, and then your direction is whichever way that superior vertebral body is going. Is it going anteriorly or is it going posteriorly? Yes, sir.
Could you say 4 and 5 as well?
Let's take a look. 1, 2, 3, 4, 5. Maybe. Yeah, that's really, that's small. So yeah, for those who didn't see it, 1, 2, 3, 4, and 5. So right here, super subtle. But if I draw my lines, it does come in just a little bit. And if I do my posterior one, it does come out a little bit. So I would buy that. Good eye. And that's an example of not looking at the shiny toy and looking at everything else afterwards, right? Now, academically, can't give you both as an answer choice, so I had to give you one or the other if that was what I wanted you to find. But clinically, that's very important. And this is why counting the vertebrae is important, because you got to be able to notify the neurosurgeon or neurology or sometimes ortho, because they have ortho spine at some places, which ones are affected. Does everybody see that? Questions on the spondylolisthesis? We're going to see more of that as we get into the lumbar and other stuff as well too. So we're going to have more practice in naming these things and seeing it. We'll get a little bit later on, probably tomorrow. Right. Degenerative disc disease. Draw your attention to the colors. Unlike spinal stenosis, X-ray is the initial study and study of choice for degenerative disc disease. Why? What is the layman's term of degenerative disc disease that I just said? Arthritis of the spine. In our arthritis lecture, everything was X-ray related. We didn't do CT or MRI on anything except for maybe that infectious arthritis because it's kind of similar to that osteomyelitis, right? But other than that, everything else was X-ray. So degenerative disc disease, X-ray is your initial study, your study of choice. Yes, MRI can add more detail, but that's really only if you're concerned about some kind of impingement on a nerve or a ligament or something that's causing some of the pain. You're not looking at it for the degenerative disc disease, you're looking for the impingement on that soft tissue structure, right? So, X-ray. So, what are we going to have here? It's almost always age-related, right? This is something that we get as we get older. We're all probably going to get this. Those of us who were in more physically demanding career fields prior to coming here probably get it a little bit sooner, right? Because it's arthritis of the back. You're going to have radicular pain, stiffness. Some patients can be asymptomatic and you find it accidentally on X-ray. Why do I bring this down for you? Because what's going to happen is you're going to get a lower back X-ray just because they have back pain, and all you're going to find is degenerative disc disease. It's not going to be super severe. You're like, this is not what's causing your pain. I knew it was muscular because I pushed on your paraspinal muscles and you said, ow, right? But I got you the X-ray just to make sure I didn't miss anything, and you're going to have to explain to the patient, hey, I know it's degenerative disc disease. That just means arthritis in your back. You're 57. That's normal. We expect that. There's nothing to worry about. This is still muscular. No, you don't need an MRI. That's what they all want. So what does that look like? That looks like, was that? Yeah, MRI always fix the problem, right? You are looking for disc space changes. in relationship to the area you're looking, right? So one of the great things about lateral spine x-rays is you have your comparison sitting right there, the other disc spaces, right? Most of the time it happens lower. So if I look at my lumbar, look at the pretty disc space here, here, and look at how narrow it gets down here in L5S1. So really nice disc space, really nice. Start to lose a little bit of the height, almost no disc space here. Same thing at my cervical here. I got pretty good disc spaces up top, and then I get down here with what, let's see, 1, 2, 3, 4, 5, 6, yep, C7T1, and it's almost non-existent. This one over here, it's more at 1, 2, 3, 4, 5, C5, C6 disc space. And then look, it even opens back up more at C6, C7. So you use it in comparison to the other ones. When you start to have that narrowing of that disc space, that's your degenerative disc disease starting to be the arthritis. Eventually there's going to be osteophytes. Eventually this will get a little bit worse, right? The disc space might go away completely. But this is why x-ray is the study of choice. We can see it really nicely on those x-rays. Question on those disc spaces. I don't need you to know how big they're supposed to be, because you're just comparing them to all the other ones. And really, let's say it's like the whole lumbar spine. Eventually, you're going to see enough normals to where you're going to know that this is about the normal disc space that you should be having. So if you have it in like all of the discs of the lumbar spine, you're like, oh, that's narrow. That's definitely supposed to be larger than that, because you will have seen a bunch of normal lumbar spine x-rays, right? If I give you something like this, I will make sure that it has an image with the normal disc spaces, and it shows the narrowing of those disc spaces as it goes down, so you can pick up on that, because you're not at the stage yet to where if I gave you this little, an image with this little sliver of disc space for all of those, to be able to know that that's abnormal, right? But you will one day be able to do that. Hopefully in about 8 months when you go to phase 2. Kidding, 21 months when you graduate. All right. Compression fractures of the spine. More commonly women than men. Why?
Osteoporosis.
Say that again? Lack of muscle could be a factor, yeah.
Osteoporosis.
Osteoporosis, right? Remember where it affects most. That femur and the spine. So the spine is the weight-bearing bones of our body for the most part, for our torso. So if we end up having osteoporosis and we lose some of that stability, we're going to get compression fractures. More commonly in women than men. X-ray is your initial study, right? MRI is your study of choice. MRI we're going to use only if we feel that we need to distinguish compression fractures from osteoporosis versus some other kind of malignancy, right? I can't tell all the time if it's a cancer in the spine or not from just an x-ray. But if I have other history or other symptoms, right? Osteoporosis isn't causing unexplained weight loss. Osteoporosis isn't causing night sweats or unexplained fevers or things along those lines. So if I find a compression fracture, my patient is having some of those symptoms, probably going to go to an MRI to make sure it's not a malignancy, like a cancer, causing the compression fracture as opposed to your standard osteoporosis. Okay? X-ray is your initial study. Most often involves the anterior superior portion of the vertebral body. Okay? They end up with that pain in the mid-thoracic or upper lumbar area, so right kind of in this region is where it's at the most. That's the primary area of the weight bearing that we end up having. Usually not neurological symptoms at all, because this is more vertebral based. It's not anything to do with the spinal cord. I'll show you some pictures of what they look like. So again, the one on the left is normal. And then here's my compression fracture on the other one. Notice how it's involving the anterior superior portion of the vertebral body. I have a nice, pretty shaped vertebrae above it. And then this one kind of slopes off. And then the one below it looks like a nice little rectangular shape how it's supposed to be. There's my compression fracture. It'll stand out more when you look at some of the thoracic and the lumbar ones. That's more commonly where it's at, but it can happen in the cervical spine as well. Right? And it's not necessarily a slippage, because if I line this up, sure, my anterior is over here, but look at where my superior one's shifted in, but look at where the inferior is at. If I draw my full line, they're all pretty lined up here. They're all pretty lined up, except for just this one corner, right? It's not the whole vertebrae that's shifted over. And that's why that's one of the things that the compression fracture, as opposed to the spondylolisthesis, is it's not all shifted over. It's just, that's fracture there. So if it was there, it'd be good. Yeah.
Get a re-image for that?
If I got this film, I would probably ask him to reshoot it, yeah. I agree. That's grainy, not the greatest quality in the world, right? If you ever start doing searches for things online with like different images and stuff like that, outside of it, you'll find that sometimes it's hard to get like really beautiful like this for abnormalities. Because this, look at all the stuff behind here. All that stuff behind right here, all that noise, all that kind of artifact where, that's a pillow for a bed and some sheets. So this was likely shot in the ER, which means they likely shot at what's called a cross table lateral. So they just put the film here and just shot it across, which is why we get the poor quality. But it's the best that they can get. So sometimes the answer is no, this is the best I can get because of the circumstances of the patient. But you can at least ask that question, like, hey, can we get a better image? Yeah.
Are we gonna have like the fracture for the third one? Are we gonna have the fracture in the distal portion of the
This year?
Yeah.
Not all the time. Depends. But good eye, right? So it depends on how bad the compression fracture is and just how it fractured on that person. This is not one where like, hey, you're gonna have that anterior superior compression fracture and this will always be there as well. It just happens to be in this case. Here's what it can look like on CT. This one's a little bit more severe, right? We can tell it's definitely compressed compared to the other vertebrae. And then not only that, we broke posteriorly, and now I got a little piece of spinous, vertebral body floating in my spinal canal. Right? So this one might be causing some neurological symptoms or pain just because of where it's floating, but typically compression fractures do not in themselves.
Is this one?
So if we're counting the CT, right? One's up here because of the spinous process. This would be 2, 3, 4, 5. So C6 is what's compressed. Right? If I'm asking you to count vertebrae, right? It's kind of unfair on this one because I don't have all of them kind of sitting right here. Most of my name-its are either going to be on X-ray or it's going to be, if it's a CT, you're going to have to be very clear and have all of them kind of sit there. I don't like to work in ambiguity for the most part. Okay, questions on the compression fractures? We will see some more of those as we get to some of the practice images. Yeah. All right, herniated discs. All right, herniated discs. Don't need to go through the pathophys of that. We learned that last semester. This is one, still at pain, still at back tightness and stiffness, a lot like the degenerative disc disease, but now all of a sudden, I'm having radicular symptoms, right? Primarily following a dermatomal pattern, which means before you even get the imaging, you can probably guess where the herniated disc is based off of where they're saying they're having that neurological pain, if you remember all your dermatomes. When you remember all your dermatomes, right? Because they're like, oh, I have it like in this L. That's probably L3, L4 area, right? Because of where you're having the pain. You're still going to get the imaging to confirm that, but you might have a good idea before they even get there. Again, the difference between the degenerative disc disease, right, and the herniated disc is neurological symptoms or no, for your suspicion. Most often occurs in the lumbar region. Okay, why? Because that's where most of our weight is carried. Those are the ones that herniate the most, right? And people don't know how to lift their legs, so they lift with their back, and boom, there goes the herniated disc. If it's in the cervical spine, it's going to be in the lower part of the spine, the C4 through C7, really C5 through C7, but technically C4, C5 is good. Thoracic, very rare. Very, very rare. For the thoracic to have a herniated disc, it has extra support with the ribs coming into the vertebrae. So it's very rare for them to herniate. It can happen, but it's not very common. And yes. So cervical spine x-ray is going to be your initial study in those ages 50 and older for sure. But really your MRI is your study of choice, right? Because what am I looking for? I'm looking for a herniated disc. How well was I able to see those discs on x-ray or CT? I can't. So I need to do the MRI. This would be one of the only MRIs that I would expect you to read and find an abnormality on. Because it's right there. And we've already looked at MRIs before, and we turn around and be like, okay, so there's the spinal cord and there's the cerebral spinal fluid, so I have an idea of what it's supposed to look like, and when I have the herniation, it's pinching in, and my fluid is not this nice little white line that comes all the way through, and I can see it kind of pinching the spinal cord a little bit. So there's the disc herniating into the spinal canal. This would be one of the only MRIs I could throw on there, and I would expect you to be able to pull it out and say it's a herniated disc. So if I were to count, can I count them? Yeah, this is the only spine. So I can go C1, 2, 3, 4, 5, 6. C5, C6 herniated disc. This is the top vertebrae right here. From what I can see on this picture, right? From what I can see on this picture. Probably if I give you a herniated disc, guys, it's probably going to be lumbar spine. So it's going to be a lot easier to count. Because you can go from the bottom up.
So on the left picture, sir, so the CT vertebrae is that picture, sir. And it shows the damage there. That's what I'm showing.
So these are two different pictures though. They're not the same patient. So yeah, these are two different. One's a, see how it's a little bit different here? Like these aren't the exact same patient. Yeah. Like I said, if I give you this and I want you to count it, it's all of my herniated discs are lumbar, right? Because they're a lot easier to read, they're a lot easier to tell, they're a lot easier to count. Because when you see a sacrum, which we'll see, you can just go, oh, where's the sacrum? So L5 and count upwards.
Are we worried about C2, 3 herniating? Or is there a mild herniating?
Here?
Yeah.
Yeah, so, yes, for those that are looking, maybe a small one here, definitely a small herniation here. There's a herniation there as well. Maybe a little bit there, but really this is the big one, and then I do see one there as well. The other ones are kind of questionable. I would want the full, if I was in clinic, I would want the full MRI to scan in and out of to really try to see it and look at all those pictures. But this picture alone, I would be confident in saying here and here for herniations. Here and here. Yeah. Here's your lumbar ones. And here's what I'm telling you, like when you know your anatomy, here's the sacrum. So it's really easy to count up and go L5, L4, L3, whatever we're doing there. Sacrum, so S1, L5, L4, L3. So here, you can see how closely the cerebral spinal fluid goes down through the canal, and then I got that bulge sitting right there. So cerebral spinal fluid comes down, bulge right here, and then comes all the way down there. So this would be an L4, L5 disc herniation, posterior disc herniation. Everybody see that? Okay. What do we got going on here? Osteophytes, right? Not quite degenerative disc disease yet, I don't think. Maybe down here a little bit, but these two are pretty similar. And look at what I'm missing. I am missing so many. C1, C2, 3, 4. I only got the C5 on this patient, right? 1, 2, 3, 4, 5, and I can't see below that, right? Again, this is a patient who is bedridden, hence the button on the hospital gown right there. So they are inpatient, and that's the best that they can get. It's another perfect example of why we like to go to CT if we're concerned about major abnormalities in the cervical spine. But yes, those are osteophytes. What do we got there? primarily this one. Compression fracture of which vertebrae? L2, good. How do we do that? Sacrum, 5, 4, 3, 2. Now, that's the lateral. If I'm doing the frontal, oh gosh, where's the sacrum and the L5? Well, look, I have ribs that go into T12. T12, L1, L2. 3, 4, 5. So much like a cervical spine, you count on the frontal from the top down, that last rib is T12, go down, but on the side view of the lateral, we count from the sacrum and go up. How many more blue slides do I have? I'll let you guys practice that one on your own and see if you can name it. And that one. Questions? Alright, so we'll see you tomorrow. Practice those last two. Try to name those spondylolistheses. See if you can. If you have any questions, let me know. We'll see you tomorrow.